Good afternoon, everyone. I'm Lim, speech therapist from Hospital Moi. Today, I would like to present my topic on the swallowing in tracheostomized patient. This is the contents of my talk. We will go through the normal process of swallowing. What is dysphagia? What is the effect of tracheostomy on swallowing? And lastly is the dysphagia management in tracheostomy. So let's start with the normal process of the swallowing. There are 4 phases in swallowing. The first phase is oral preparatory stage. Second stage is oral stage, and followed by pharyngeal stage, and lastly, esophageal stage. So I will highlight each stage in the next slide. Now I would like to draw your attention to the diagram on the right side. So this is the side view of the anatomy of the pharynx. Okay, as you can see here, the upper lips and lower lips. Going further in is your teeth, and there's a very large, the largest muscle at the floor of your mouth is a tongue, and above there you got the hard palate and soft palate, or we call it velum. Okay, so further downward, okay, to the back of the tongue, this pocket we call it as valleculae, and behind valleculae you will have epiglottis. Okay, so epiglottis function is to cover the airway so that the food or liquid doesn't go into the airway. And over here you can see there are 2 tracks of passage. All right, so the front part here is the trachea. Okay, it's a trachea which has the vocal fold that vibrate to produce the voice. Okay, and is further connect down to the lung. Okay, and at the back here you have the esophagus. Okay, so the food, when you swallow, the epiglottis will cover up the airway, so the food is transported down to the esophagus. All right. Okay, so now looks at the first phase, which is oral preparatory phase. Okay, so imagine in front of you there's a plate of nasi lemak. Okay, so oral preparatory phase starts when you look at the nasi lemak and it looks appetizing with lots of colors like the red sambal, the rice, the green cucumber. It looks appetizing and you can smell it. It smells good. So at the moment you smell and see the food, the oral preparatory stage is begins. Okay, so immediately you put a spoonful of nasi lemak into your mouth. So what happens is both of your lips will start to close. All right, so your jaw will start to chew the food. Okay, and the food in your mouth is mixed with saliva, and your tongue will try to manipulate the manipulate the food to form it into a bolus. Okay, so then as the bolus actually is propelled posteriorly towards the back of the throat. So if compared to the phase 1, the bolus is still in the middle of the tongue, yeah. But in phase 2, the bolus is already propelled towards the back of the tongue. And at this moment, the velums actually raise up to close off the nasal airway so that the food doesn't get regurgitated back into the nose. All right. The pharyngeal swallow is triggered, yeah, when the tongue propels the bolus towards the back of the throat, yeah, and the bolus reach valleculae. So at this moment, when you put your fingers on your Adam's apple, you actually can feel your larynx is going upward and forward when you swallow. All right, so your epiglottis will close off the airway to prevent penetration or aspiration of food. and the bolus is directed to the hypopharynx, yeah, aided with the pharyngeal constrictions. So behind the epiclotidae, yeah, there's a muscle at the top of the esophagus. We call it as upper esophageal sphincter, a UES. Okay, so the food, when the bolus arrive at the UES, the sphincter will automatically open up to allow the bolus to enter the esophagus. So when the bolus have passed through the esophagus, the esophageal phase is begin. All right, and this UES will close off immediately after the bolus pass through the UES. Okay, so that's the end of the esophageal phase. Okay, so now let's look at the a video. Yeah, it's a normal swallow that is carried out under VFSS, a video fluoroscopy swallowing study. Yeah, in my facility we don't have VFSS. We are doing more on fees. So later I will show you a video of fees. Okay, so let's look at this video. Okay, swallowing water. So you can see here uh, there is no pooling of water after the patient swallow. Second swallow, yeah, is very clear and very fast swallow reflex is triggered. Yeah, this is a pudding tip. Okay, chew the food. And swallow, yeah, it reached the valleculae and is pushed downward. All right. Okay, let's talk about dysphagia. What is dysphagia? Dysphagia is a swallowing disorder characterized by difficulty in oral preparation for the swallow or in moving materials from the mouth to the stomach. So it means that throughout the 4 stages of swallowing, if any problem happens in either stage, yeah, you will have the dysphagia, the swallowing problem. So it can be a patient's post-stroke. Okay, so he has the lips drooping, unilateral lips drooping. So when he is drinking water, the water may coming out from the lips. Okay, which means that the lip cells is not strong. Yeah, um, or another example, it could be when uh, the patient is drinking water, but it takes such a long time for him to swallow the water. Yeah, so you can see the swallow reflex is triggered very slowly. Okay, so this is the sign and symptoms of dysphagia. Okay, so causes of dysphagia include brain injury following stroke or accidents, cancer of the cancer of the head and or neck, surgery on the structures of the mouth, and etc. Okay, so now let's look at a video of dysphagia under VFSS. Okay, after swallow, you see there's a pulling at the valleculae here and going down here. Okay, after third swallow, yeah, there's still pulling over here. Okay, patients start to cough. All right, all right. Okay, so Our specialist and medical officer have explained about tracheostomy, so I won't explain more on that. So I just want to share about the effects of tracheostomy on swallowing. Okay, so uh, these are some of the effects that tracheostomy can bring on the swallowing functions. Okay, so the first is impact olfaction. For normal people, we breathe through the nose. Okay, but for tracheostomized patients, they actually breathe in through the tracheostomy, and the air actually on exhalation it actually comes out from the tracheostomy as well, which means that the air actually has bypassed the nasal airway. So actually it create a sort of like a dead zone over the nasal and the mouth area. Okay, so we know that the sense of taste, okay, is also largely related to the sense of smell. Okay, so in a tracheostomy patient, they have a very reduced sense of smell, which can affect their ability to take the food. As I shared just now, in phase 1, we need the oral preparatory stage, yeah, when we see the food. Okay, so the second effect of tracheostomy on swallowing is a reduced subglottic air pressure. Okay, so I want to share a study by Gross et al. In 2003. Okay, physiologic effects of open and closed tracheostomy, tubes on pharyngeal swallow. All right, so the aim of this study was to compare the depth of laryngeal penetration, bolus speed, and duration of pharyngeal muscle contraction during swallow in individuals with tracheostomy tube. Either their tube were open or closed. Okay, so I believe this diagram up here is a cuff tracheostomy without the speaking valve. So it's a open tracheostomy. And the diagram here below, as you can see, there's a speaking valve attached at the tracheostomy. So it is actually a closed tracheostomy where you breathe in through the tracheostomy, but when you breathe out, the air actually is directed through your nose and your mouth. So in the sense that it actually creates a subglottic air pressure, yeah, below the vocal fold. Okay, and this subglottic air pressure is very important in swallowing, to swallow safely. Okay, so the result of this series of experiments indicate that within the same tracheostomy patient, pharyngeal swallowing physiology is measurably different in the absence of subglottic air pressure as compared to the closed tube condition. Okay, so it means that the closed tracheostomy is more safe. It has less laryngeal penetration. Okay, okay. Okay, so the following effects impact laryngeal elevations, okay, as highlighted by Ding and Matthew, okay, and also desensitization of the larynx. Actually, what happens in there? Let's look at some journal, okay. So this journal is written by Matthew in 2012. We study the influence of the cuff pressure on the swallowing reflex in tracheostomized patient. So it said that the effect increased with greater cuff pressure, especially above 25 cm H2O. Okay, and the swallowing reflex was progressively more difficult to elicit with increasing cuff pressure, and when activated, the resulting motor swallowing activity and efficiency at elevating the larynx were depressed. So you know that just now in pharyngeal swallow, the larynx need to move upward and forward. Okay, so imagine if there's a tracheostomy anchored at the larynx, okay, it's going to give some friction for that movement. Okay, so again, Ding written a journal on swallow physiology in patients with tract cuff inflated or deflated. Okay, so the results show the frequency of reduced laryngeal elevation and silent aspiration were found to be significantly higher in the cuff inflated condition than the cuff deflated condition. So this study actually highlight that when we want to let patients swallow, okay, we need to deflate the cuff first, okay, because the cuff inflections added with the over pressure cuff actually can pose higher risk of silent aspiration. Okay, so we move towards the last stage of our presentation, dysphagia management in tracheostomy. So there are three types of swallowing assessment that we can conduct in patient with tracheostomy. So the first one is a very common one, clinical bedside swallowing assessment. Okay, so of course, first we need to collect the history and interview the patient, such as the reason for intubation, duration of intubation, okay, and of course some medical history. Okay, next we will conduct oral motor examination to examine the strength, speed, and range of motions of the jaw, lips, tongue, and soft palate. Okay, so if we think that this patient is fit for oral trial, so we need to deflate the cuff so cuff deflection simultaneously with suction is done with nurse. Okay, so because we will assume that the secretion actually pull above the cuff. Okay, so if we straight away deflate the cuff, the secretion may straight away go into the lungs. Aspiration happens. Okay, so we will do while deflating the cuff, the nurse can do the suctioning or do the suction before deflating the cuff. Okay, so okay, we will monitor the SpO2. If patient doesn't desaturate, okay, looks good, so we will put the speaking valve, to get the patient talk or so that we can hear the voice, okay, and the ability to use the vocal fold to cough is so important to protect the patient from aspirating. Okay, so next only we will give oral trials of different consistencies of water or solid food. Okay, so the second type of swallowing assessment is blue dye test or modified events blue dye test. Okay, this is commonly done in patient with tracheostomy. Okay, so first thing we do is we deflate the cuff. Okay, okay, so with blue dye test oral trial with only one consistency of food or fluid, it means that we don't want to mess up this patient is uh, actually aspirated on water. If we give two consistency of liquid at the same times, we cannot find which types of consistency that patient is aspirating. So we always use one consistency of fluid only, and suction is done immediately following trials and throughout the 24 hours period. Okay, so if blue dye secretion is found, this indicates that the individual is aspirating, and we may want to put him on rice tube, keep him on rice tube first. But if blue dye is not found in the trachea secretion, this, however, does not indicate that the individual did not aspirate. Okay, it could be a false negative, means that the patient is actually aspirating, but it doesn't show in the blue dye doesn't show up in the secretion. Okay, so in the conclusion, okay, blue dye test is just a screening test. Okay, and not to rely completely on it, and because studies show it has a very poor sensitivity of 10 to 50% accurate in assessing if aspirations occurs. Okay, so normally what we do and what we prefer to do with tracheostomized patient is instrumental assessment. Okay, so just now I show you a video of VFSS. So in this slide you will know Hpsf, and I usually do fees with my ENT team in hospital MOA. Okay, so this is the individual who have penetration on both liquid and solid materials. And this patient actually
just
cough.
Swallow when you're ready.
Okay, after swallow,
good, that's enough.
The severe pulling, and the bolus actually going into the airway. This is your airway. Okay.
Alright. Okay. Just a small bite. Chew it up, and we have the water ready for him to swallow. But hold on, the cracker all went down, huh? Oh no, some of it's still there. That's okay. Don't give me more water.
Okay, patient start coughing because of the aspirated. So based on the swallowing assessment, we will give the swallowing therapy. And our swallowing therapy is mainly rehabilitation, is either rehabilitation techniques or compensatory strategies. So rehabilitation technique is an exercise or maneuver carried out to improve the physiology of swallowing in order to recover normal swallowing function. So if the bedside assessment in oral motor examination, we find that, oh, this patient cannot open the mouth in an adequate range of motion, so we will do a jaw exercise. Okay, open your mouth and close your mouth. Okay, we will do 10 times each set. Okay, so normally patient have to do morning, afternoon, and night. Okay, and rehabilitation techniques needs to be carried out. Needs to be carried out every day. Yeah, then only you can see the result. Okay, so the second is thermal tactile stimulation, which is very well known to be used in patient with tracheostomy. Okay, because patient with tracheostomy, they have the very desensitized larynx. Okay, when you give water, the swallow effects is triggered very late. Okay, so this TTS is you put a metal spoon into a cup of ice. Okay, so that the metal spoon is have the cooling effect. Okay, so you make sure you use a small metal spoon because you want to swipe at the this one anterior facial pillar. Okay, you swipe 3 times on the right side, also 3 times, and we ask patient to swallow. Okay, we believe that TTS actually can increase the swallow reflex. Okay, on the right side is the shaker's exercise. Shaker exercise is used to open up the UES. Okay, if you still remember the UES, if food is pulled on the UES, we may ask patient to do a shaker exercise. Okay, so next we will look at some compensatory strategies. Okay, so compensatory strategies is a strategy which is carried out to change the process of bolus, food or drink transfer. It gives an immediate result, okay, without changing the physiology of swallowing. So this is the difference compared to the rehab exercise. Okay, so you have the postural changes, chin tuck. Okay, so why we are doing chin tuck is normally for patient with delayed swallow, we will ask them to put their chin down, then only swallow. Yeah, because chin tuck can widen the valvulae, narrows the airway, and increase probability that bolus remain in a valvulae before the patient starts swallow. On the right side is head turning to the weak side of which side of the pharyngeal is weak. Like we see there's a pulling, let's say on the left side, then the patient have to turn to the left side and swallow. Okay. Okay, lastly, we have diet modification. Okay, so for fluid, liquid, actually we can, if the water actually flows very fast in nature, so we can thicken it up to mildly thick, moderate thick, like honey, and extremely thick, which is like a pudding. Okay, so that patient have time to control the bolus. Okay, so for food, we will start with a very simple that diet that doesn't need chewing, which is the smooth puree. Okay, and then mince and moist. We means that we chop up all the vegetable broccoli into small pieces that doesn't require much chewing. And last, this one is a soft diet. You can see there's the steamed broccoli which needs a bit of chewing. Okay, so all this exercise, we will decide based on the swallowing assessment. It doesn't mean that all exercise will fit a patient. Okay, we will need to decide. Okay, so that's reached the end of my talk. This is my references. All right, and thank you.